So if you think that there is only one way to recover from addiction problems, then this presentation won't be useful to you. But I think it was astonishing, given the diversity of human beings and the diversity of substance and behavioral addictions, that there would be only one way to recover. And I'll present a way, which will be useful to some people. So self-empowering, we'll distinguish that from powerlessness as we go. Leading, because Smart Recovery is the largest of the alternative or non-12-step mutual help groups. Mutual help, self-help, mutual aid, support, those are used somewhat interchangeably. If I'm careful, I'll always say mutual help tonight. If you catch me saying something else, raise your hand. And Practical Recovery, yes, is a program that's 29 years old now in San Diego, 2 rehabs, a sober living, and outpatient services. Smart Recovery is a completely distinct nonprofit, international nonprofit organization. The connection is that I'm the president of both, so that gets confusing. At Practical Recovery, we do moderation training for some clients. Smart Recovery is an organization that supports abstinence, so that's another potential confusion. How many of you have heard of rational recovery? Okay, so the old timers there are raising their hand. Rational recovery still exists. It was the self-help, well, this organization, Smart Recovery, was the mutual help side of Rational Recovery until 1994, and they split. So Rational Recovery still exists, but it doesn't offer mutual help groups anymore. So it's not really relevant in this discussion. So these are the take-home messages which I have already given to you, that recovery is diverse, and Smart Recovery might be one way that somebody could recover. And that self-empowerment piece we'll talk about in a moment. You know about trade slogans. You remember Nike's trade slogan? Just do it. And McDonald's? I'm loving it. Is the businesswoman. She knows. How about Starbucks? Do they have them? But this is our trade slogan. Discover the power of choice. We haven't actually registered this for federal government, but we will soon. And that's the acronym. The organization is a nonprofit. We have separate subsidiary organizations in the UK and Australia and New York City, but otherwise everything runs out of a central office in Ohio. We have about 1,000 meetings. We surpassed 1,000 meetings this last fall. And besides offering these groups, I'm just going to move this. Besides offering these groups, we support the concept of choice in recovery. This is an overview of the program. Any substance or behavioral addiction, could call it a process or activity addiction also. We, maybe 5 years ago, made the decision. We had talked about ourselves as a group that supports individuals who view addiction as not a disease. But then we realized that all of our tools work regardless of what you think about that issue. So we didn't really have to change anything other than saying, it doesn't matter what you think about that issue. There are several issues that it doesn't matter. You can believe in God or not, you can believe it's a disease or not, you can call yourself an addict or an alcoholic or not, it doesn't matter. Our tools could be helpful either way. And the meetings are, if you're used to 12-step meetings, filled with crosstalk. They are discussion meetings. The best meeting, we tell our facilitators, is the one where you get it started and then you're quiet, because the rest of the group is carrying forth with that discussion. We do not have a sponsor system, which is potentially a disadvantage for some people. The way to deal with that issue is either do 12-step instead of Smart Recovery, do 12-step in addition to Smart Recovery, go to a lot of therapy, or do something else. But everything in Smart Recovery happens in a group. This approach is the intersection of 3 factors. Is it self-empowering? I'll describe that in a little more detail later. Is there a scientific foundation for it? And would it work in a mutual help group? There are medications which are evidence-based for treatment, but we're not going to be passing those out in a mutual help group. I put this here because I assume you're familiar with it, and I want to use it to illustrate the concept of self-empowerment. I rewrote it very slightly to begin with an emphasis on courage. Now, this is either way you word it, this is a great formula for life. It's a description of issues you're going to need to address. And we all need both courage and serenity. As I thought about these concepts, because I'm often speaking to more 12-step oriented audiences trying to gain understanding or acceptance for smart recovery and alternative methods, I would start, as I do now, with this Serenity prayer, because it's language people know. And I would first say, if you want to emphasize courage in your recovery as opposed to serenity, that's not so much 12-step, that's more smart recovery. And as I thought about it further, I came to the image of a tree. A tree, as above, so below. The roots only go as deep as the branches go high, or vice versa. And courage and serenity, I think, operate in the same expanding polarity. And there are actually many things in life that operate this way. So my capacity to accept the realities of my life. I just turned 60 last week. It was an interesting reality. Thank you. And at the same time, the courage to act on the things I can, which is just what the prayer or the intention talks about. There will be individuals who emphasize courage over serenity. Smart recovery is more suitable for them, but again, people can attend both groups. So locus of control is the underlying psychological variable. It's been studied since the 1950s by Julian Roeder at Ohio State University, and now hundreds, if not thousands, of publications on it. And it refers to your perspective looking forward. As I look forward in life, will my life be about what happens to me? It will partly. Or more about what I do. If you think your life will mostly be about whether you win the lottery or not, whether you get hit by a truck or not, that's an external locus of control. The power resides more outside of me. Internal locus of control is no matter what happens to me, I'm going to lead a valued life. When we, a life based on my values, when we see someone who, say, had a horrible war injury or born with a disability or whatever, and they still lead a valued and meaningful life, we're very inspired by these individuals because they have not just accepted, they've accepted, but they've also acted with courage. So locus of control identifies this preferred orientation. That's looking forward. Looking backwards, there's a companion theory called attribution theory, and it helps understand the past. So, this gentleman, why is he sweating? So think of the answer that just popped into your head, if you had one. You have an answer that goes in one of two directions, probably. Now, you've got a funny look on your face. You may have something that surprises me, but did you think this is a nervous individual, or did you think it must be hot in there or he was exercising? One is an external explanation, one is an internal explanation. Okay? Did you have something different? Okay. A formula for happiness. As you look backwards in life, find situational explanations. I did that because it was hot, I was poor, I was young, I got bad advice, whatever, something outside of you. As you look forward versus I'm really screwed up. As you look forward, flip that on its head. My life is going to be about what I choose to make it based on my values. And I think you'll find that's a useful way to think about how to live. So, self-empowerment, courage, smart recovery. These are the kinds of things that we would say. If someone wants to use the term alcoholic, we don't object, but we don't push it either. We talked about having cost exceeding benefits, so it's time to change, but some of our participants, in fact, about a third of our participants view addiction as a disease, about a third don't, and a third either haven't decided or don't care, which is an interesting finding from our annual survey. The results of our annual survey are on our home page. You can click on them for the last 4 or 5 years. We talk about choosing to change rather than having to change. This is a crucial step. It can represent the change that someone evolves to in longer-term recovery. In early recovery, they might be saying, really, I got to do this, I can't do this anymore. I can't keep using Coke or whatever. But as one matures in recovery, it's something one has chosen to do. And for everyone in recovery, there's some transition period, typically 90 days, but maybe longer. So we encourage people to think about this project, which is not going to be as hard in a year or 2 years as it is right at the beginning. It really does require major focus at the beginning, but you're not going to focus like that forever. So everything has a context. These are the contexts that I'm going to describe quickly. This is the list of variables that we think of as diversity variables. People are very different on these issues. We could put a few more that might have legal or ethical significance, but I'm listing now the diversities that are meaningful to clinicians. SES is socioeconomic status. As you think about these factors, they make a difference in how you conceptualize your client or your patient. So I want to propose that recovery has a similar range of diversity. And when you think there's only one way to recover, it is what I have termed recoveryism. And I had forgotten this term, which I coined about 10 years ago. And about 6 months ago, Bill White emails me and he says, I want to cite this term you coined years ago, and I actually put it in the Smart Recovery newsletter. So Smart Recovery got its quarterly newsletter is now in one of Bill White's publications, which I was just tickled by. So most people recover naturally. That is, they don't go to treatment, they don't go to a mutual help group, they just get it together on their own. They're not the people we see in the treatment system. It's easy to ignore them, but they're a very important guide to what recovery consists of. And then there are people who just touch in there briefly. Might go to a meeting or two, might go to a session or two, maybe go to a rehab for a week. They're in and out quickly, and then of course there's the cases that are sort of our bread and butter cases because they're in and out of our facilities, perhaps much of their adult lives. These are the ways in which recoveries can differ. This slide and the next one, and one of the main points of this is that just because you know the standing on one of these variables doesn't necessarily tell you the standing on another one. So someone could have made a major life transformation, the third one there, in order to be successful. But it doesn't tell you whether they did 12-step or smart recovery or didn't go to a mutual help group at all. They're not connected. Similarly with alcohol, just to make the comparison. If I have major legal problems from drinking, what does that tell you about my medical problems? Nothing. If I have major problems at home from drinking, what does it tell you about my problems at work? Nothing. If I have major central nervous system problems from drinking, what would that tell you about my liver problems? Relatively little. So these are disconnected issues, and that's part of the significance of talking about the diversity of recovery. How many of you know Faces and Voices of Recovery? Okay, this has become the leading advocacy organization for people in recovery. The only comparable one would be NCADD, National Council on Alcohol and Drug Dependence. Faces and Voices has published a Recovery Bill of Rights. And I quote from 2 sections of it because it's very clear here. There is no one path to recovery, and people in recovery need to know about the many pathways to recovery. So this is an advocacy organization that I hope everybody would come to learn more about and support, and this is its suggestion about diversity in recovery. So that was diversity. Let's talk about other mutual help groups. Of course, the big player has been, since 1935, AA. And I've listed here the beliefs, the foundations of the AA approach, which to people who have found AA helpful are essential. Most people will point to these issues and say, this is what worked for me. And to other individuals, they'll point to the same list and say, this is why I could never go there, or this is why it wouldn't help. Now, regardless of what you think about AA's approach, and clearly millions of people attribute their recoveries to AA. So that piece, I said that very carefully, and I'll come back and explain it later. But that piece, that millions of people attribute their recovery to AA, is a fact. The organization, established in 1935, spawned dozens of other 12-step groups. Crucial piece is that from a scientific perspective, if it were considered as a treatment, its efficacy is unknown. And that's not because it's not effective. The reality is we don't know, because the studies that would be needed to say how it's effective have not been conducted. I believe with very little doubt that when the studies would ever be conducted, we would establish that AA is effective for some people. And I also further believe that it would be, given a broad range of options, perhaps the only approach that would work for some people. How large that group is anybody's guess. Regardless of how effective AA is, the biggest issue is that most people who might benefit from being there won't go. And of those who go, most don't stay. So you can't benefit from something you're not participating in. The United States treatment system is almost entirely based on the 12-step approach. Now that 93% is a little bit old, that's maybe 10 years old. I don't know that it's changed that much. The biggest problem with the US treatment system is that it is not diverse enough. We have roughly 20 million people in the United States right now who could benefit from some level of addiction treatment, and nowhere near that number in treatment. There is the hope that we could pull more in if we had a more diverse system. So that's why we do Smart Recovery. We do have 12-step based facilitation. This is the last line, which is an evidence-based addiction treatment. It's not AA itself. It's psychotherapy that encourages one to participate more effectively in AA, or let's say in a more engaged manner. These are what I've been calling the alternative support groups, starting with Women for Sobriety in the mid-70s. Is there a Women for Sobriety meeting in Orange County? Anybody know? Not sure. They've 300-400 meetings approximately, mostly in the United States. SOS, the second one, started in the 80s. Tends to really pull for atheists. Rational Recovery, I put in parentheses because, as I said, since 2000 it no longer offers mutual help groups. Smart Recovery began in 1994. Moderation management is often maligned, but it supports individuals to moderate or abstain from alcohol. One of the fastest ways to abstinence for a lot of people is to begin a concerted approach to moderate. And when they actually begin an effortful, deliberate, comprehensive approach to moderation and it still doesn't work, an intelligent person will see that there is another road I need to consider. And I've talked to lots of people who said if MM hadn't existed, it would have taken me another 10 years to get to AA. But I got to abstinence within the year through MM. So, it's a valuable addition. Life and Secular Recovery was an offshoot of SOS, and HAMS is probably the most radical group there. Harm Reduction, Abstinence, and Moderation, hamsnetwork.org. It's more of an online presence at this point. This survey is now 16 years old. I don't know that it's that different though. Do you remember the Yellow Pages? In 1998, we opened up the San Diego Yellow Pages and called all 38 listings under alcoholism information and treatment centers. And had this is a little bit deceptive. We said, I had Jeff, one of my staff members at the time, make the call. I'm calling on behalf of my girlfriend. She knows she has a drinking problem. She completely admits that. And we went to the doctor, and he said, go to AA. So we went to AA, we went for 5 meetings, and she said, you know, those are really nice people and they are really well-intentioned. I just don't think that approach will work for me. So we went back to the doctor and he said, I don't know what else there is. So I'm just going through the yellow pages, I'm calling people, can you tell me, you guys do alcoholism treatment, is there something else? Well, 47% said there are others that exist but they don't work. 45% in the blue said no, there's really nothing else. And 3 out of 38 got the answer right, which there are other approaches and they might be helpful. So if you ever hear a colleague saying AA is the only approach to recovery, and I just heard it a month ago, I think it's important to say, you know, actually there are other approaches. So that was other groups, scientific findings. Regardless of whether you view addiction as a disease, people in recovery need to make better choices. They need to manage situations. Much of relapse prevention programming is teaching people how to manage situations, identify high-risk situations, and avoid them at the beginning. That's the safest thing to do. There are co-occurring disorders, and they are very common. Probably over half of the people who admit to treatment at any level are going to have some level of diagnosable co-occurring problem. And then if you look at what might be called subclinical problems, I can't imagine somebody coming into treatment. I think we had one client once in the thousands of people we've seen now, who I thought maybe this guy is just a pure substance user, but everybody else has got some, I mean, is anybody here with only one problem in life? You know, it's not too believable. We have a number of treatments, which I'll talk about, and I've already mentioned that natural recovery is the leading way out of recovery, into recovery. If you want to verify this, write down this expression. Alcoholism isn't what it used to be. Google that phrase. Alcoholism isn't what it used to be. And the first hit will be a federal government paper from NIAAA, National Institute on Alcohol Abuse and Alcoholism. Alcoholism isn't what it used to be, and it will show you the findings from the NESARC, N-E-S-A-R-C, the National Epidemiological Survey on Alcohol-Related Conditions, published in 2006. The reason we have the DSM, starting with DSM-3, was to create a reliable and valid diagnostic system so that the federal government could, and other researchers could go out and say, okay, you're subclinical, you're alcohol abuse, you're alcohol dependent, you have no problems, and could actually classify people. And in clinical practice, the value of that may be less, but if you're trying to figure out how many beds should we have in this country and how many outpatient slots should we have, you'd want to know this sort of thing. So the NESARC goes out and uses sophisticated statistical methods, including stratified random sampling, and identifies 43,000 individuals living in the United States and identifies a subgroup of 4,224 individuals who at one time in their lives merited a diagnosis of alcohol dependence. Okay, so that's DSM-4. DSM-5's got different terminology. Alcohol dependence could be a synonym for alcoholism. It's the most severe alcohol disorder you can have. Average age of diagnosis, 22. 13% of these people actually went to treatment at some point. 75% of them recovered on their own. No treatment, no mutual help group. And of those, half of them were moderated. Pretty dramatic result, and it's not the only one to show that moderation is a possibility, that natural recovery is a possibility. What we get in the treatment system are the more severe cases with lots of comorbidity. Moderation becomes much less likely, depending on the severity of the case. But I will say for clinical reasons, at Practical Recovery, we do not make a recommendation on this subject. And this is one of the things I wish everybody would do. It makes us still radical. This is your choice. Let's think very intelligently, because you know, if you have another binge, I'm really concerned about what's going to happen. And then if you know the client, you talk about all the things that have happened. But it's your choice, because more important than anything in addiction recovery is motivation. When you've had a client who was motivated to screw up the treatment plan that you created, everybody's had those clients, right? Right? They just are a nightmare. So when you get them to pick their own treatment plan, they tend to do that much less. If you want a review of alcoholism treatment, this book's now a little bit old, but at the time it collected every randomized clinical trial in the scientific literature, over 350 of them, for the treatment of alcoholism. And did a very sophisticated methodological examination and drew some conclusions about what works, what doesn't yet work, and what doesn't work. I'll come back to some of those findings. This is available for free on the internet, and it lists 13 principles, but I pulled out a few just to show that smart recovery is consistent. No single treatment is appropriate for everyone. This is similar to Faces and Voices saying there's no one path to recovery. Effective treatment is holistic, number 4. Number 6, behavioral therapy, psychosocial treatment is important. Medications can be important. We never push those on anybody, but we want to make sure they know that all of them are available. And comorbidity in number 9. So, when I say what works, there's this distinction. I keep wanting to put this down, but I really want to. There is a distinction between effective and efficacious. And efficacious is what works in a tightly controlled, randomized clinical trial. Effective is what would work in the real world. And almost nothing gets tested in the real world. Everything gets tested in these efficacy studies. So this is the best we can do at the moment. What I want to point out is, as we look at efficacious treatments, how diverse they are. So behavioral couples therapy is about focusing on the substance use, but also on marital communication, assertiveness, mutuality. Very effective. CBT, I assume you're all familiar with particularly with an emphasis on relapse prevention. So we've got one that focuses on relationships. The next one is focusing on thoughts and to some extent activities. Contingency management is a behavioral, rewards and punishments kinds of approach. Motivational interviewing doesn't make any recommendations about anything and asks a lot of questions. Doesn't teach anything. Doesn't give any rewards. It's just really a series of questions. That's a very different approach. Chemical counter-conditioning is what happens at Schick-Shadel Hospital in Seattle. Familiar with this? You drink and you get very sick, and after you've done that 4 times in 10 days, you don't want to drink for a long time. Maybe forever. Even if it only gets you 6 months of abstinence, it's a great 6 months in which you can do some of the other things on the list. There's a whole range of medications. And there's 12-step facilitation, which is also an efficacious treatment. And I put in parentheses because I consider the other ones, self-empowering 12-step facilitation, somewhat less so. Question for you to consider. Given how different these are, does this mean that we know a lot about addiction treatment, or do we only know a very little? I'm with you. I think we know only a very little. When we can't figure out what the common factors in all these are. We just got half a dozen different treatments. One study, just a few studies on smart recovery. We're applying, I don't have a slide on it yet, but in the fall, we had several comparison groups and a new smart recovery web app that's been available since about September. And if you're familiar with the National Registry of Evidence-Based Programs and Practices, it's one place to look for evidence-based treatments, and we're applying as of last month to be there because that study would give us access to that. So we could, once there, say that smart recovery itself as a mutual health group is an evidence-based approach to recovery, even though it's not a treatment. Ironically, the only other mutual health group that's there is moderation management. It's been there for a few years. So it's an evidence-based approach. This is a substance abuse and mentally ill population. And 5-year study in the late 90s, seriously mentally ill individuals in a day treatment program, comparable results in the Smart Recovery side or the 12-step side. They had to make the 12-step side less confrontational and more client-friendly just to keep the subjects in the study. There was another study in 2007 that, just a survey study, several hundred subjects, 300 or 400, looked at people who attended a variety of groups. People who attend groups get better, regardless of which group. Those who were high religious in orientation preferred AA and Women for Sobriety, low religious secular organization for sobriety, and we were delighted to see the final bullet that your religious orientation was irrelevant to your involvement in Smart Recovery, which is exactly what we had in mind. You've seen these before, right? Good. I'm so sick of this. Okay. Should you work for a government agency? You would be wise not to order someone to go to 12-step, because it's actually illegal. The United States Constitution has a Bill of Rights. The First Amendment talks about freedom of religion, freedom of press, freedom of assembly. The clause in there that's relevant is, quote, Congress shall pass no law respecting an establishment of religion or prohibit the free expression thereof, unquote. AA was ruled religious enough that if the government orders you to attend, it would be comparable to ordering you to attend the Episcopal Church or a Buddhist temple or whatever, so that's a no-no for the government. Other people can require you to do that, your boss, your spouse, whatever. And in this last ruling, the government worker who sent somebody back to prison as a parole officer, and then that person died in prison, was held personally liable for the damages. So that was a major decision. The implication of this context is we need some more diverse support groups. I think you got that message already. So the fundamental document in Smart Recovery is 2 pages. It's a Smart Recovery purposes and methods. It's reproduced in a lot of places. Our main publication is the Smart Recovery Handbook, available for sale off the website for $10. This is what we do. Any addictive behavior, and we think of this as more than abstinence. It's actually going on to lead a meaningful life and being fully beyond it. And we have what's called a 4-point program. These are the first 2 points. This organizes everything that we do. These are not steps in a sequential sense, but they are 4 tasks that somehow people in recovery need to accomplish. They need to keep their motivation up, some way to cope with urges and cravings. They've got thoughts, feelings, and behaviors to manage, and then ultimately to prevent relapse, you want some measure of lifestyle balance. So there's a Smart Recovery 4-point program that I'm teaching to the post-test right now. So keep those 4 in mind, okay? Motivation, craving, call it problem solving, and lifestyle balance. That's the Smart Recovery 4-point program. So we evolve as science evolves, which means that our handbook is already in its 3rd edition. We're only 20 years old, and it will continue to evolve. And for those who would like to stay involved, we encourage them to do so. These are on this slide and the next slide, the primary tools that we use. So you've seen stages of change. We just ask people to consider where they are, pre-contemplation, contemplation. A change plan worksheet is a 1-page form that reminds you that if you actually want to get from here to here, you probably should think about the steps along the way, particularly the next one. And the ABC is a tool developed by Albert Ellis, recently, almost 10 years ago now, deceased New York City psychologist, who talked about A, activating event, B, underlying belief, C, emotional behavioral consequence, rational motive behavior therapy, REBT. There are 3 fundamental facts about craving. That's what this first one is about. Those 3 facts are: craving is time limited. It's going to go away. You don't have to do anything, it just happens on its own. 2, craving in itself does not harm you. It's uncomfortable and distracting, but does no damage. And 3, craving does not force you to do anything. It It's insistent, it's distracting, but ultimately you get to decide. If you have an automobile that tells you that your fuel is getting low, most automobiles do that now. Anybody driven your car all the way to being out of gas, even though it was talking to you the whole time, right? It doesn't force you to go to the gas station. It's just a message. Okay, DISARM, destructive imagery and self-talk awareness and refusal method. Sometimes people find it useful to personify craving. It's someone attacking me. It's a slick salesman. One of our Smart Recovery participants recently just talked about slick. Yeah, slick comes out and he starts talking to me, and I got to figure out how to talk back. So if it's useful to see that or think about that, that's a tool. Brainstorming we use in groups, ask people for alternative perspective. That's an important part of a mutual help group. We do role playing pretty regularly. And we try just a few more tools. Cost-benefit analysis. We always begin with what do you like about drinking, drugging, whatever. Because that tells you what needs to be replaced. Very simply, if I drink to relax, I need other ways to relax. And if you take my drinking away before I figured out some other way to relax, you are setting me up to relapse. So there's a little sort of step-by-step process. I get a little better at relaxation, I may drink a little less, however that works. But we need to be mindful that we are asking people to give up something that has worked, at least in the past, pretty well, or they wouldn't have stayed with it. The ABC of emotional upset. So I actually want to rename this and reconstruct it as the Hamlet tool. And you may remember Hamlet in Shakespeare's play. He says to his friends Rosencrantz and Guildenstern, Denmark is a prison. I say, well, my lord, no, it's not a prison. He says, well, then for you it's not. There is nothing either good or bad, but thinking makes it so. There is nothing either good or bad, but thinking makes it so. So that's what we do with an ABC. This is what happened. This is what I feel about it. This is how I must have interpreted it. And maybe I could interpret it in a different way. And that's the essence of cognitive behavioral treatment as well. USA, unconditional self-acceptance. I have as much right to be in the world as anybody else. None of us asked to be born. We didn't even know we were here until 2 or 3 years later. And we're all just doing the best we can to get through life. HOV, hierarchy of values. This is a tool we use quite regularly in meetings. What's most important to me? And as soon as I figure that out, I can probably realize that substance use or addiction is not getting me what I truly want. But it's useful. Some of this is very simple. Just writing it down on paper is very helpful. I did a trauma presentation recently, and these would be some examples of beliefs that someone with a trauma history might have that we might tackle in a Smart Recovery meeting. And that brings us to the end of it.